Guys, I'm here to talk to you about the muscarinic antagonists in this video and the nicotinic antagonists. So starting first with the muscarinic antagonists, let's think why we would maybe use these sorts of drugs therapeutically. You can see some examples of muscarinic antagonists, one of which is the plant Atropa belladonna, which is probably the original muscarinic antagonist. Probably the prototype muscarinic antagonist is atropine. So where you're really going to see these things being used is if we need to decrease GI or GU motility and or secretions of the gastrointestinal tract. So you can see a couple examples there. Peptic ulcer disease, where we might need to see some decrease in secretions either in the stomach or in the small intestine. Also decreasing cramps and or diarrhea. That's a very common use of these drugs, and also acute pancreatitis, which the utility around that is a decrease in pancreatic enzyme secretion, or the decrease in the exocrine pancreas secretions, which would then minimize the autodigestion we see with pancreatitis. These drugs are also going to relax the bladder, so if someone has an overactive bladder, they can be very useful in those cases as well. They're oftentimes used topically if we need to dilate the pupil in an ophthalmologic eye exam. They can be used if somebody has a slow heart rate. By blocking the muscarinic receptors, you would see an increase in adrenergic action at the heart, which is to increase the heart rate. They're probably not going to be used frequently for that, but that's an option. Also in the respiratory system, mostly in the cases of chronic obstructive pulmonary disease where we might need some opening of the airway. They could be useful in asthma as well, but they do quite a bit of drying of the airway, because asthma is an allergic condition that oftentimes can compound the issue, make it worse. So there are some examples of like a combination asthma drug I'm thinking of that has a steroid and a muscarinic antagonist together. Advair is the name of that. That's the brand name of that particular drug that I'm thinking of. But in terms of chronic obstructive pulmonary disease, these drugs are oftentimes used because they decrease secretions, which is the problem. They have sort of copious mucus production over the long haul and also open the airway. Parkinson's disease is complicated, and it's going to be something we're going to talk more about in Unit 6 when we do the central nervous system. But with Parkinson's disease, essentially there is a balance in the brain, in the substantia nigra, where acetylcholine and dopamine are held in balance. And with Parkinson's disease, they lose the neurons that release dopamine over a period of time. And so what that then creates is, in that area of the brain, is what looks to be like a relative abundance of acetylcholine. And so the anticholinergic drugs or the muscarinic antagonists can be used to block the muscarinic receptor and decrease the action of acetylcholine, which would then sort of try to like set the balance just at a lower level. And so those can be quite useful, and we'll talk more about that later on. A lot of our insecticides are muscarinic agonists, and so these can be used as antidotes to poisoning, especially like with organophosphates. And then finally, they oftentimes are used as a pre-anesthetic medication, mostly for their sedative effects, calming effects, which is, again, a central nervous system effect, which we're not going to talk too much about, but it's one of the side effects of these drugs as well. And also they reduce secretion, so especially if there's going to be some sort of a procedure that would benefit from a decreased secretion, like intubation, we'll see in a little bit, is a possibility. There's a whole bunch of side effects for these medications, and that usually limits the ability to use them. Unless you're using it to decrease secretions and decrease GI and GU activity, then you're probably going to not be able to use these because those actions are so profound. So there's a lot of side effects. You would expect the heart rate to go up as a side effect of a muscarinic antagonist. You'd expect a lot of dryness of the entire mucus, all of the mucous membranes, including the eyes. You'd expect GI and urinary retention unless you're already using it for that, unless you're using it for that purpose. This can be especially problematic in older men who oftentimes have an enlarged prostate, and so urinary retention is already an issue for them, and that can really be compounded by the use of muscarinic antagonists. Dizziness and fatigue, again, is another central nervous system effect, but it is quite profound in some patients and can limit the use of these. If somebody has been given a muscarinic antagonist, signs of toxicity of these anticholinergic drugs are referred to as anticholinergic syndrome. And the symptoms of that are kind of, I think, things that we can anticipate. A lot of dryness, especially of the mouth, blurring of the vision, especially distance vision, photophobia, difficulty swallowing. Photophobia is sensitivity to the light, which you would expect because they're going to have a lot of pupil dilation. Difficulty swallowing, mostly because of the dryness of the mucosa. Agitation, sorry, there's a spelling error, and hallucinations. Again, those are sort of CNS effects. It is notable that a lot of the drugs that we use have peripheral nervous system side effects. They're not used specifically for these effects, but they interact with these receptors, or they block these receptors and or these neurotransmitters, and so they can cause anticholinergic side effects. And the ones that are notable for that, of course, are the antihistamines, the tricyclic antidepressants, which are medications that are used for severe or major depression, and also antipsychotics have cholinergic blocking effects. So these side effects are quite common with those medications. In terms of nicotinic antagonists, the prototype is succinylcholine. These are not used for chronically at all. They're just too weird and variable. Right, nicotinic receptors are all over the place, so these are going to block those nicotinic receptors all over the place. But on the short term, they can be used to facilitate surgery because of their neuromuscular blockade, like in cases of electroconvulsant therapy or ECT. These would be useful. Intubation, they're useful for that, for both the muscular blockade as well as the decrease in oral secretions. And then if someone has tetanus, these drugs can be useful. Tetanus, of course, is a sustained contraction, right? It's a toxin, a bacteria that releases this endotoxin that causes sustained muscular contraction. Essentially, acetylcholine doesn't get off the receptors. So what we can use here is we can use a blocker at that neuromuscular junction for that reason. So that's not real common condition, but it's a possibility. Side effects of nicotinic antagonists, again, since they're not used chronically and or often, we don't think too much about it, but chronically we could expect respiratory paralysis because of the interference of the diaphragm, which is a skeletal muscle, of course, cardiac collapse. The interactions, there can be quite a few drug interactions, some increase and some decrease the neuromuscular blockade, where we would see an increase of the neuromuscular blockade with nicotinic antagonists would be with acidosis, some antibiotics, and some antiarrhythmic agents, and the one that's notable for that is quinidine, which we'll talk about later as kind of the prototype antiarrhythmic agent. And also, we can see a decrease in the ability to block the neuromuscular junction if somebody has low serum potassium. And of course, we would expect to see a slowing down of the GI motility. And anytime that happens, whether it's with a nicotinic antagonist or probably more profoundly with a muscarinic antagonist, we would potentially see the increase of the absorption of other drugs that they may be taking, which could get them to a toxic level. All right, so that's it for this video. That one was kind of short, and we're going to come back with the two final videos on the adrenergic drugs. So I will see you whenever it is that you choose to dive into that. All right, see you then.